Good afternoon, good evening, and good night to everyone. Welcome to the second IFSO APC webinar. And actually, this is our very first IFSO APC Integrated Health webinar. So I'm very happy to have people all over the world. I've heard people really around the globe has joined us. And I'm also very happy to have on our panelists, people from Australia, someone special from Australia, some from India. And my name is Dr. Kwang Wei Pham. I'm from Singapore. I'm actually the Vice Chair of the Integrated Health Committee of the IFSO APC. I'm also a Secretary of the Asia-Oceania Congress of Obesity, and I'm actually an endocrinologist by training and in practice at the Singapore General Hospital. And it gives me great honor and also great pleasure and excitement to host and to be the moderator of this meeting. I would like to introduce our speaker, is Ms. Caroline Remedios. Caroline is actually a team leader in nutrition and patient services at Dr. Murphy's Digestive Health Institute. And she is actually an accredited practicing dietitian. And she has actually a master's in dietetics from Deakin University in Melbourne, Australia, and also a specialist in sports nutrition. Caroline actually has had a wealth of experience practicing with Dr. Murphy in the area of bariatric surgery, and she's actually published quite a number of papers in this area, and she's going to enlighten us on the topic as we've published. With me is also a panelist, Ms. Stephanie Gilroy. Stephanie is an accredited practicing dietitian and nutritionist at the St. George Private Hospital in Sydney, Australia, as well as the Macquarie GI University Clinic. And she's also an honorary clinical lecturer at the Macquarie University in New South Wales, Australia. So please welcome the two of them with me tonight. Tonight's topic is actually very, very relevant, and often we take nutrition as a part of bariatric surgery, part of bariatric medicine, but truly how important it is, be it pre-op or post-op. And we ourselves come from different parts of the world, different parts of Asia even, and different parts of Asia with different diets, different cultures, and how is that really going to affect the nutrition of our patients? So I think today we're really fortunate to have Caroline to enlighten us on that. But before we start, we're actually going to do a quick poll. All of you will be able to poll on this question, and when the question is posted, you have about 10 to 20 seconds, and please interact with us and let us know your thoughts. We're going to start the poll right now before we start the talk proper. So the first question is pre-op assessment by a nutritionist or dietitian, should that be mandatory? Yes or no? All right. I think we're still collecting responses here, sorry. About 17% more of people. All right. So good majority of you feel that we need a pre-op assessment. Caroline and Stephanie, you definitely have a job to keep for a long time to come. Let's move on to our very next question, our next poll, which would be, should nutritionists and dietitians counseling patients for bariatric surgery undergo specialized training in bariatric nutrition? Strongly disagree or disagree? Oh, sorry, it should be strongly agree. Actually, there's a series of 5. Just poll your thoughts there. All right. Okay, I think most of you do agree that we should have nutritionists undergo some serious training before they counsel patients. Let's move on to our next poll. Pre-op assessment by nutritionists should be, do you believe that there should be country or culture-specific nutritional guidelines for bariatric surgery? All right, I think there's a little of mixed feelings here, though about maybe 70% of people feel that there should be some specific nutritional guidelines. And then the next question there. Pre-op assessment by, I subscribe to the following guidelines in my nutritional supplemental practice. Please pick one of the answers. All right, that's good. I see that quite a number of people have their own countries and local guidelines, which is very helpful. If not, most people prescribe to ASMBS and ASPEN guidelines. All right, thank you for your participation in the poll. We're actually going to start the talk proper. And to share with us will be Caroline Remedios on the importance of bariatric nutrition and the current worldwide guidelines. Caroline, thank you.
Thank you so much, Wang Wei, and welcome to our first Integrated Health IFSO APC Integrated Health webinar. And it's very exciting that we've chosen bariatric nutrition because it's very close to my heart. So just to sort of understand whether we actually need guidelines, and do we actually need a multidisciplinary team? Just give me 1 second. I don't think my slide is moving here, but just give me 1 second. It's not moving. Okay. All right. Sorry there, guys. We just had a little bit of a technical hitch. But just to sort of understand whether a multidisciplinary approach is actually needed for the care of bariatric surgical patients. And if you can see on your screen there are a lot of societies globally that actually think that a multidisciplinary team approach is actually very vital to the care of bariatric surgical patients. So who exactly should be involved in the care of a bariatric patient? Other than the surgeon, obviously, we definitely need nutrition expertise. We need an endocrinologist on our team. We need a psychologist, and in addition to a physician and to nursing to actually be able to give the best care to our patients. Knowing that we have multiple types of surgery that are being done all over the world, and also some surgeries which are very region specific, surgeries that are specific to specific clinics, it is important to understand where the nutritionist actually needs to be competent. So these are just a few pointers in terms of what is needed from a nutritionist to be able to give the best care to our patients. So number one is actual understanding of the different types of bariatric surgery, surgeries that are done in your specific part of the region, and surgeries that are done across the world as well. Very, very important also is to understand that you need to have a proper pre-assessment of your patient. You need to understand your patient thoroughly. You need to understand his likes, his dislikes, his eating patterns to be able to counsel him pre-operatively and post-operatively. The other most important thing is actual knowledge of which surgery will cause which nutrient deficiency to be able to actually supplement your patient accordingly. And of course, something which is extremely vital are what kind of medical emergencies that can be prevented by a nutritionist. And to name a few would be B1 deficiency, which can actually cause irreversible damage like wernicke's encephalopathy, protein energy malnutrition, which could be very common, hypoglycemia, and liver failure. So in what sort of situations do we actually need a nutritionist? And I believe that we need a nutritionist right from the preoperative stage right up to long-term situations. And we'll go through each one of these situations in my next slide. As bariatric nutritionists and those who are practicing bariatric nutrition, preoperative diet is a standard protocol, and we all are doing this in our day-to-day practice. And there's a lot of literature on this, but also what's more important to understand when we are actually prescribing a preoperative diet is to understand that our patients do not come in only with obesity, but they come in with a myriad of problems. And it is important to be able to modify our preoperative diet to suit the need of the patient. So a few examples as to where we need to modify a preoperative diet is our patients that are insulin dependent. So in order to be able to prevent hypoglycemia, we need to make sure that they're having their meals frequently, that we have an endocrinologist on board who is able to monitor and adjust their insulin dosage. You will have patients who have high uric acid levels, and in that sense, we need to make sure that we're low in purine content to limit the sources of non-vegetarian protein, and to also make sure that they're hydrated well enough with water. Liver disease is another biggie. You will have patients who will come in with compromised liver function, and the key here is to make sure to avoid severe protein restriction and to calculate their protein requirements accordingly. You might also need to adjust their sodium and their fluid in case of ascites or hypernatremia. Renal disease is another problem that you will face preoperatively. Here it is important to make sure we give our patients high biological value protein. You might need to adjust their potassium, their sodium to make sure that the electrolytes are not haywire. And in conjunction with the nephrologist on the team, you might also need fluid restriction sometimes. And there will be cases when you might have patients with cardiac disease, and there could be occasions where you might need to adjust fluid and sodium in that case as well. So it's always important to keep in mind these few instances where you might need to adjust your preoperative diet. The other situations that we come across fairly routinely in the immediate post-operative phase are things like nausea and vomiting, constipation, acidity, bloating, flatulence, excessive gas. These are common things that most of your patients will come back with, and most of them can actually be managed with just simple education to the patient in terms of chewing their well, eating slowly, sipping enough water throughout the day, making sure that there's not too long of gaps in between their meals, and also simple things like avoiding straws, avoiding chewing gum to sort of reduce intake of gas. So these are simple things where a nutritionist can actually make a difference to ease that transition of your patient. However, amongst all of these situations, there is one situation that is not normal, and that would be in case your patient comes in with persistent vomiting. I'd like to just stress a little bit upon this slide because in case of persistent vomiting, you need to remember that it could lead to thiamine deficiency, and that could lead into irreversible damage if not corrected immediately. So if you do have a patient that comes back to you with persistent vomiting, it is imperative that you supplement them with thiamine injections, either intravenously or intramuscularly, immediately, even in the absence of lab reports, because it is important that you do not reach a point where it will be difficult to get back your patient from neural damage or damages where they're unable to walk on their own, or even severe damages, irreversible damages like the Wernicke's encephalopathy. Important in this case to also remember is that thiamine is stored in very small amounts in your body, so which will require constant replenishment. And that is why it would be a good practice to actually supplement your patient with a B complex supplementation for the first month of their surgery to avoid situations like thiamine deficiency. Also important that if your patient does come back to you in case of dehydration, a common practice is to actually give them an IV infusion, but it is also imperative to make sure that you actually have B complex vitamin added into this infusion, again, to prevent thiamine deficiency. Dumping syndrome and hypoglycemia. Again, I've sort of clubbed this in one slide because most of your late dumping syndrome will actually cause hypoglycemia. And hypoglycemia can be actually very, very distressful to a bariatric patient. It adversely affects the patient's quality of life. And if it goes undetected or untreated, can actually cause, again, irreversible damages. In case your patient's blood sugar drops down too low, it could cause a lot of neuroglycopenic changes, which we don't want. So I think when it comes to hypoglycemia, it is important for us as nutritionists to be able to recognize the symptoms of hypoglycemia, recognize what habits of your patients are actually causing these symptoms, and to then treat it accordingly. Also important that you will probably need the input of your endocrinologist in this case, in case nutritional intervention doesn't solve this problem. However, just to take you through what you can do in terms of nutritional management if your patient does come back with hypoglycemia. So the important things to remember is to be able to understand how to treat the low blood sugars promptly. Important also to prevent over-treatment of hypoglycemia, which could then cause rebound hyperglycemia. Then again, it is important to educate your patients to prevent future episodes of hypoglycemia, and also to be able to treat them so that we don't cause weight regain in the long term by constantly treating hypoglycemia with simple sugars. So what do we do then? First, we need to educate our patients about hypoglycemia and dumping syndrome. We need to educate them on complex carbohydrate meals, explain to them the kind of meals that they need to be incorporating in their daily diet, mix of complex carbohydrate meals with optimal protein intake. You can also use fiber supplements in this case to be able to manage their blood sugars. Educate patients to avoid refined foods, sugary drinks, and alcohol. And also something which might go unnoticed but could play an important role to prevent hypoglycemia is actually avoiding drinking fluids immediately post a meal. However, if all else fails and nutritional intervention doesn't sort of stabilize your patient's blood sugar levels, it is important to recognize that it is now time to refer this patient to our endocrinologist, who can then prescribe certain drugs to be able to manage their blood sugar levels. I know that the prescribing of these drugs are actually the work of an endocrinologist, but we as nutritionists should know what kind of drugs are available. And I would sort of urge you all to read up about a drug called acarbose, which is commonly prescribed to be able to manage hypoglycemia in post-bariatric patients as well. Now coming to the state of deficiencies and nutritional deficiencies. When we do see an obese person, I think the first thought that comes to their mind is that the patient is probably overnourished. However, for those of us that have been working with bariatric patients, we do understand that these obese individuals actually have a very high incidence of nutritional deficiencies, and they actually come in with severe malnutrition. Now, what are the causes of these nutritional deficiencies in our obese population? The causes are multiple. It is poor food choices, long-term side effects of medications, their sedentary lifestyles, and also their chronic dieting that they've been going through can cause multiple deficiencies in this set of patients. These are the 5 most commonly seen nutritional deficiencies in our obese population, and those of you working with bariatric nutrition will commonly see them in your patients as well. Now, these deficiencies can be exacerbated post-bariatric surgery for a multiple of reasons, and I've listed down the most common ones here. The most common ones are first and foremost to reduce intake of food because of small pouch sizes. There will be a reduction in gastric acid and intrinsic factor in both restrictive and malabsorptive procedures. Procedures that bypass the duodenum and parts of the jejunum will also cause malnutrition of those certain nutrients, delayed mixing of pancreatic juices and gastric juices. And of course, probably the most common things are food aversions and intolerances that most of our patients face in the immediate post-op phase, and sometimes these intolerances also last in the long term as well. Now, if I were to go through each of the nutrients, the couple slides that follow will actually show us which nutrient is deficient and for what reason. So first, coming to iron, because of the lack of gastric acid post-bariatric surgery because of the resection of the stomach, you will have a reduction in the conversion of your iron to the most absorbable state. Procedures where we actually bypass parts of the intestine will also cause a malabsorption of iron, and of course the increased gastric emptying and delayed intestinal transit time. Vitamin B12 again is very commonly seen because of the reduction in gastric acid, which sort of hinders the release of the bound form of vitamin B12 from food. There's also the fact of the reduction of the intrinsic factor because of the resection of the stomach. And also bypassing of majority of the stomach and some part of the intestine will also exacerbate vitamin B12 deficiency. Calcium again will be caused because of reduced gastric acid production and also bypass of your most active absorption sites, which are your first part of your intestine, like the duodenum. Vitamin D3 deficiency will be caused in procedures that bypass the jejunum and the ileum. Vitamin D3 deficiency is also caused because of delayed mixing of bile juices and also reduction absorption area. Protein is another big nutrient. Though we know that protein is absorbed in almost the entire GI tract, it can be of a problem, especially in your immediate post-op phase because of your reduction in the food intake, because your patients come with multiple food aversions and food intolerances, and most of these aversions and intolerances tend to be towards protein-rich food. Sometimes that could cause protein deficiency. And in procedures that basically bypass a lot of your intestine, like your SRDS, your BPD, and your duodenal switch, you will have protein deficiency as a major problem on your hands when dealing with these kind of procedures. Folic acid, again, like vitamin B1, is in very small amounts in the body, and it will require constant replenishment. Deficiencies could occur again because of the reduction in food intake, and also when you're bypassing, parts of the intestine where your folic acid is actually absorbed, which is in case of your malabsorptive procedures. Fat-soluble nutrients and trace elements, again, these are more pronounced in procedures that actually bypass length of the intestine. So again, procedures like your SADI, your BPD and DS, these trace elements and fat-soluble nutrients will be more pronounced in these procedures. Like we've seen in the past few slides, it is important as a nutritionist to understand what surgical procedure is actually going to cause what kind of deficiency, and also very important to recognize the symptoms of these deficiencies to be able to replenish and replace these vitamins. And replacement of vitamins and minerals is extremely critical for the success of bariatric surgery. And for those of us who are sort of just starting off into bariatric nutrition or are not sort of sure how to supplement our patients, there are multiple guidelines that have already been published world over. I think the most reviewed one is probably the ASMBS guidelines, which was published in 2008. Most of us have sort of gone through these guidelines of actually supplement our patients because of the depth in which the authors have actually helped us with sort of picking out each nutrient and giving us the actual supplementation dose. Again, there have been guidelines that have been published by the International Diabetes Federation, which also sort of gives us in terms of how to manage these patients. So we have guidelines that have been published by the European Society. We have the British Obesity Metabolic Surgery Society, which has also adapted these guidelines to suit their set of population. And of course, we also have the guidelines that have come out from Asia, which is the Bariatric Nutrition Guidelines for the Indian population, which was published in 2016. So these guidelines sort of help us nutritionists to be able to manage our patients according to the deficiencies. And just to give you a snapshot of what is available out there, so you guys can actually download it and actually see it and use them in your practice. The ASMBS guidelines published in 2008 actually goes by per procedure and actually helps you pick out which surgery would require what supplementation and in what dosage. Very specific to each procedure, they talk about fat-soluble vitamins, trace elements, and everything that you will require for the care of your patient. The IDF statement also sort of lists down procedures that entail your gastric banding, your sleeves, your Roux-en-Y gastric bypasses, and your malabsorptive procedures. It also helps you to sort of decide what nutrient would actually require additional supplementation in which type of procedure. Then, of course, you have the guideline that has been published by the American Association of Clinical Endocrinologists and the ASMBS, which also sort of goes per surgery-wise. This is just a snapshot of the routine nutrient supplementation that has been prescribed post-bariatric surgery. And of course, you have the guidelines that were published by the European chapter of IFSO, which specifically entails supplementation for procedures like the like the BPD, which actually talks about the actual dosage of your fat-soluble vitamins and calcium, specifically for malabsorptive procedures. Then again, like we spoke about, the British Society has actually adapted a lot of these guidelines and specifically mentioned names of supplementation and multivitamins that that can be bought over the counter. So these were adapted from the ASMBS and the European guidelines to suit their population. However, when we're coming closer to home and coming closer to our region, we need to understand that our diet patterns, specifically for our population in Asia, is probably very, very different from the Europeans and from the Americans. So I've just sort of given a snapshot of a few of the cuisines that are available in Asia, and it is probably an oversimplified version of the diet. But just to bring to your notice that the staple foods are actually very different to what we would find in other parts of the world. So if you go through the Chinese cuisine, for example, the staple is actually rice and noodles, which are either made from wheat or rice or steamed buns. They have a lot of vegetables and fish and meat in their diet, but the staple actually is rice. Similarly, with the Japanese cuisine, staple again is rice. They eat do eat a lot of fish and seafood because of their proximity to the sea. But again, going down here, the staple food is rice to begin with. Coming to the Indian cuisine again, major part of our meal surrounds wheat, rice, and millets. We do have a lot of pulses that we sort of include in our diet, a lot of variety of vegetables, and meat in most parts of the country is optional because primarily most of our population is actually vegetarian. And across the entire country of India, you actually have different parts of the country that have very, very different sort of eating patterns, different kind of foods that they eat. Most of these sort of foods that are eaten across the country are specific in terms of taste, in the kind of cereals that are used. So it's very sort of diverse across one country itself. So the point that I'm actually trying to bring across is that different countries and different regions will actually have different cultural eating patterns, different foods that they're eating. So deficiencies will also differ depending on the eating pattern. So coming again back to the Indian deficiencies, and these are the deficiency rates of Indian population that are just the general population. So we already have a very, very high deficiencies of iron, B12, D3, calcium, and protein in our general population. So when we come to the obese population again, these deficiencies are again showcased because of the sort of obese condition of our patients. So we have a general population that is already extremely deficient in these nutrients, and then we have obesity sort of that exacerbates this condition. And the cause of these deficiencies are actually primarily because of the kind of diet that is eaten in our country. So if you look at the per nutrient reason, we actually see that even though we eat a lot of iron-rich foods, we're actually consuming the non-heme iron, which is actually less absorbable in our system. Most of our diets are vegetarian. We have a high intake of tea and coffee, which also hinders iron absorption. Coming down to B12, again, major reason for deficiency is our vegetarian diet. Though we do have a large set of non-vegetarians as well, the intake of meats is not as high as compared to our Caucasian counterparts, for example. Coming to vitamin D3, the main reason for us being deficient, even though we are in a tropical country, is because of skin pigmentation, which sort of hinders the absorption of vitamin D3. Again, vegetarian diet exacerbates that D3 deficiency. Again, coming down to protein, though we do have a lot of protein in our diet that comes from pulses, comes from whole pulses, because of a vegetarian nature of our diet, we do not get a complete protein, and hence we always tend to lack in a few amino acids because of the diet. And until and unless our population actually learns to combine a proper cereal and pulse combination, we are going to be lacking in the complete protein. So all of these reasons that I've listed down actually shows that our population, an Indian population, is actually deficient in a lot of these nutrients, primarily because of our eating patterns, of the kind of foods that we eat on a day-to-day basis. And hence, we came out with recommendations that were primarily made for the Indian population to be able to deal with the deficiencies that come out of our population. Nutrients to stress upon here are vitamin B12, which needs